I think the topic of discussion is simply a reflection of the fact that we're reaching a therapeutic inflection point in the treatment of acute myeloid leukemia. By that, I mean that really ever since Watson and Crick in the 1950s, Jim Watson, of course, died last week, remarkable joint contribution in terms of defining that DNA was the basic structure of life. Since Watson and Crick discovered DNA in a small Cambridge garret in the 1950s, literally trillions of pounds of taxpayers' dollar money, I mean, pounds, dollars, euros, whatever the currency, have been poured into basic biology, understanding how the changes in the DNA within our cells trigger the development of diseases. We're specifically talking about leukemia today. And although remarkable progress had been made in this period, in terms of actually understanding what went wrong at a cellular level to create a leukemic cell, until about, I think it's fair to say, probably about 15 years ago, very little of this knowledge that had been generated because of the incredibly generous donation of tax dollars, tax pounds, tax euros by patients' parents or their grandparents over this long period could really plausibly be shown to be changing treatment outcomes for patients with acute myeloid leukemia. We were good really up until about 15 years ago about risk stratification, defining whether patients had poor prognostic outcomes, but we were very um, uh, poor really at demonstrating whether this scientific information translated into new treatments for patients, new treatments at the bedside. And that's really all changed in the last 15 years. And the story of FLT3-mutated acute myeloid leukemia and the evolving treatments really is a great example of how we're beginning to use this scientific information to actually improve the day-to-day existence of patients with acute myeloid leukemia. And I think one of the great values of patient and ambassador forums such as this is that the voice, the patient voice, uh, is now very important. We have to be saying it's all very well having made these wonderful advances in laboratory science and understanding of basic disease biology, but patients need to see these new treatments as quickly as possible. So, as you will probably be aware, acute myeloid leukemia is a blood cancer which originates in the bone marrow stem cells and early blood cells, really grandfather cells or stem cells, uh, uh, have an acquired mutation in their DNA, abnormality in the DNA. And as a result, the cells fail to mature properly. They either grow much too quickly or they just fail to develop into mature neutrophils or lymphocytes or platelets or red cells. So patients with acute myeloid leukemia typically present with fatigue from anemia, easy bruising from a low platelet count, or recurrent infections. And the diagnosis of acute myeloid leukemia is therefore often made by primary physicians, but sometimes it's an incidental finding in a general medical checkup or as part of a more complex presentation in hospital. And when we see a patient with newly diagnosed acute myeloid leukemia, we want to first check out how they are clinically. We want to look for examples of bruising, bleeding. We want to check they don't have any active infection and check that they're actually clinically stable. We're also extremely interested in understanding their past medical history and their previous record of fitness. And this is very important as we consider subsequent treatment, including stem cell transplant. And so when I sit in my clinic on a Monday morning, one of the most valuable questions I have to ask in otherwise fit adults is, what were you doing 3 months ago or 6 months ago? And for us to assign fitness, we don't really have a good, robust scoring system. But actually, what level of fitness a patient had 3 months before they presented with acute myeloid leukemia is a pretty good guide. You know, were they walking 2 or 3 miles a day? Were they cycling? Were they swimming? Were they running? Or were they perhaps the sort of patient who has so many other medical problems that they found it difficult to walk more than 200 yards or difficult to get out of the house? So very important to understand the clinical presentation and how fit the patient is. It's also really important to have an understanding of the social network around the patient. Do they have caring responsibilities? Who's at home? What's their house like? Do they have stairs? And do they have a good social support network? And the other really critical factor is often how far do they have to travel to get to the hospital. So once we've got a clear idea about the physical presentation of the patient, their fitness, and their, you know, their a broader picture of their clinical presentation, we check blood tests, which will often show either a raised white cell count or low white cell count and low platelets and no neutrophils. And then to confirm a suspicion of acute myeloid leukemia, we do a bone marrow aspirate, a needle put into the pelvic bone, and a small part of the liquid bone marrow aspirated and looked at under the microscope. And the tests we do on that bone marrow aspirate would be firstly to look at whether there are leukemic cells present by eye. We're quite good at doing that. They are primitive cells, leukemic blasts, and you can pick them out quite easily. And then we would be checking that bone marrow test separately with what's called a flow cytometer, incubating those cells with some simple antibodies that will light up leukemic cells, running through a machine that looks at the light generated, and that will help with a diagnosis of acute myeloid leukemia. And so at the conclusion of that piece of work, we can confidently say whether a patient has acute myeloid leukemia or not. Meanwhile, there are some really important tests that inform future treatment cooking in the laboratory. And these would be an analysis of the chromosomes within the leukemic cells to see if there are any abnormalities. But also, and this is becoming increasingly important, to see in genes that we commonly seen have abnormalities in acute myeloid leukemia, whether this particular patient has any mutations in this panel of genes. It's called next generation sequencing. And when you go to see your doctor, this is important information you'd want to ask for. So we are able now to get a better sort of fingerprint of a patient's acute myeloid leukemia, which is specific to their disease, and that biomarker fingerprint is typically based on abnormalities in the chromosomes, abnormalities in particular genes we know are mutated in acute myeloid leukemia, and sometimes levels of protein that we can measure in the blood. And the importance of this fingerprint of disease presentation is only now becoming clear. It's important for two reasons. Firstly, it allows us to predict with some accuracy how well a patient will respond to either intensive chemotherapy or, in an older, unfit patient who's getting venetoclax, a venetoclax-based regimen. That's useful. But secondly, is it can identify us particular mutations where we know we have good drugs that may be effective in treating that particular patient. So, as I said, mutational analysis is done on the bone marrow aspirate, occasionally through a blood test, but routinely through a bone marrow test at diagnosis, if the disease comes back at relapse. And there are a number of molecular technologies that are used. Polymerase chain reaction is similar to the test for amplifying a very small amounts of DNA that we use actually in investigating crime scenes now, to just look for very small amounts of DNA and expand that. And then, as I say, also we're looking at the DNA level about whether there are mutations in genes we commonly associate with acute myeloid leukemia. So we're talking, excuse me, today about mutations, abnormalities in a gene called the FLT3 gene. And typically, the mutations that we see in the FLT3 gene, we call them internal tandem duplications, result in the FLT3 gene being slightly longer and also constitutively activated. So what do I mean by that? I mean, it's a little bit like a FLT3 gene is necessary to control growth of a cell, but when you have a mutation in a FLT3 gene in acute myeloid leukemia, it's a bit like having an accelerator on your car, and instead of the accelerator going down as you press and then coming back up as you release your foot, when you press down on a accelerator in FLT3-mutated AML, when you remove your foot, the accelerator stays down. So these cells are programmed to proliferate, and that's why typically FLT3-mutated acute myeloid leukemia presents with very high white counts. So let's look at FLT3 mutations now. They are the most common genetic change in acute myeloid leukemia, found in about 30% of people. They result in constitutive activation of the FLT3 gene, which is a driver of stem cell proliferation and maturation. And when the FLT3 gene is mutated, the blood stem cells proliferate out of control. And this is underlies the biology of this and the presentation of this disease. So one of the first things we want to do when a patient presents with acute myeloid leukemia is see whether they have evidence of a FLT3 mutation. And we are able to do that in the laboratory now because of the polymerase chain reaction and other molecular technologies that can look to see whether this particular expanded gene with the FLT3 internal tandem duplication is present. We know it's important to identify whether patients have a FLT3 mutation, because not only does it identify that they have a harder to treat leukemia, but also, as we'll discuss in a minute, they're susceptible to FLT3 inhibitors. There is another mutation in the FLT3 gene, less common, called the TKD, tyrosine kinase domain mutations, and these occur in about 10% of patients, and they are less likely to be associated with a very high white count, but they are druggable by certain targeted agents. In other words, there are particular FLT3 inhibitors that not only knock out FLT3 ITD positive cells, but also those with a FLT3 TKD. So it's really important to understand that measurement and detection of the FLT3 ITD or FLT3 TKD mutations is a core part of the diagnostic workup of every newly diagnosed patient. And also, as we'll come to in a minute, we want to look at it in patients whose treatment initially responds to chemotherapy and then relapse. So how does this information inform our treatment? And I think the real excitement is that we now have chemicals, drugs that are pretty well tolerated, that can be taken by patients, and when absorbed, they specifically block cells with the overactive FLT3 gene, and that slows or stops the growth of those leukemic cells and largely leaves healthy cells unaffected. So this is what we call a targeted therapy. Now, there are a number of FLT3 inhibitors out there, and how they work differs, and whether they work on both a FLT3-ITD mutation or a TKD is important. So we have FLT3 inhibitors such as midostaurin, which is what we call one of the first wave, the first generation, and that works in patients with both a FLT3 internal tandem duplication and also a FLT3 TKD. It's quite a difficult drug to take. It doesn't taste very nice. It doesn't smell very nice, but it's been shown, as we'll discuss in a minute, in randomized studies to improve outcomes for patients with both FLT3-ITD and FLT3-TKD. We have gilteritinib, which is what we call a second generation FLT3 inhibitor, rather more sophisticated, less toxicity, better tolerated. And again, this works in patients with both FLT3-ITD and TKD. And this is now the standard of care for patients with relapsed disease. And then quizartinib, which is a new FLT3 inhibitor. It's a second generation, again, has a different mechanism of action from midostaurin, but it's highly effective in patients with newly diagnosed AML who have a FLT3-ITD mutation. It doesn't target patients with the smaller and rarer FLT3-TKD. So it's great. In the last 10 or 15 years, we've moved from a cupboard being entirely bare for patients with a FLT3 mutation to having 3 drugs, and there's more in development that we can think of using as part of the treatment package for patients with newly diagnosed AML. So how might we use them? Well, we could use them at the start of treatment when we give intensive chemotherapy to bring the blast count down and put patients into remission. We could talk about them being a part of the consolidation treatment with intensive chemotherapy. Increasingly, there's evidence that actually giving FLT3 inhibitors when you've stopped intensive chemotherapy or when you've had a transplant, maintenance therapy can improve survival. And then, of course, certain patients are unfortunate enough, having had this effective treatment, for the disease to come back. And there are FLT3 inhibitors that are active in relapse disease. So, to be clear, if you are newly diagnosed and fit with acute myeloid leukemia and have a FLT3 mutation, not only will you get the intensive chemotherapy, in America it's called 3+7, but it's 2 drugs, daunorubicin and Ara-C, daunorubicin and cytisininib, which kill the proliferating leukemic cells, allowing you hope, to move towards a position after 1 or 2 courses of chemotherapy where the blast population, the primitive leukemic population, is less than 5%. And at that stage, we call that a complete remission. So if you have a FLT3 mutation, you would now, in addition to having that intensive chemotherapy, also receive a FLT3 inhibitor. And both midostaurin and quizartinib have been shown in big randomized studies to improve the survival of patients with a FLT3 mutation who received not only intensive chemo, but also either midostaurin or quizartinib. Now, this is a disease that has a significant chance of coming back, relapsing, if treated with chemotherapy alone, and therefore stem cell transplant is a proven and highly effective curative strategy, which should be considered in all patients, even if not delivered, but it should be considered in all patients. Consolidation chemotherapy it is important after patients have got into remission, and you give blocks of chemotherapy with a FLT3 inhibitor. But many of these patients will go on to a transplant. And what's become clear is that patients who have a transplant have a better survival. But by giving maintenance therapy, in other words, tablet therapy after you finished your transplant, either gilteritinib or quizartinib or midostaurin, you will improve the outcomes of patients having transplant by reducing relapse risk if you maintain these patients for 12 to 24 months on a FLT3 inhibitor. And this principle, which initially was pioneered primarily in transplant, also is now applicable to patients who don't proceed to a transplant, have just had blocks of chemotherapy, and can be maintained exactly the same for a year, 2, sometimes 3 years, with the drugs quizartinib or midostaurin. And then finally, sadly, still a number of patients, despite having intensive chemo and quite often a transplant, the disease can come back. And what we see in this setting is that FLT3 inhibitors, notably a drug called gilteritinib, which is just a tablet, can be better than intensive chemotherapy to get people back into a second remission. And so gilteritinib is a really important treatment in the setting of relapsed FLT3 positive acute myeloid leukemia. Most patients treated with FLT3 inhibitors tolerate them pretty well. With some of these drugs, particularly midostaurin, there's a significant nausea, and some patients just don't like it because it tastes so unpleasant. But otherwise, the side effects associated with FLT3 inhibitors, whether it's midostaurin, quizartinib, or gilteritinib, are relatively modest. Of course, some of these agents can put down the number of blood count, the number of white cells, but that's actually manageable by holding the drug or giving an injection that helps with the white cells. Sometimes feel some flu-like symptoms. Occasionally, the cell counts can change significantly, so patients feel really unwell. Differentiation syndrome, that's unlikely. GI problems, as I've mentioned, are the most significant, probably mostly with midostaurin. And with quizartinib, there have been occasional reports of changes with heart rhythm, but in the big randomized studies, that wasn't a significant problem. So let's just think about how we go through trying to understand the treatment care that is being recommended by the medical team and making sure that we are on track with what should be delivered. So the first is your medical team wants to help you as much as anybody else. So if you have questions that aren't clear about your treatment or questions about alternative approaches, please write them down and bring them in. Usually when patients are being counseled properly, the number of questions that they have is quite modest, but sometimes there are really important issues that the doctor or the clinical nurse specialist won't have been brought up. And the most important thing is that patients have ownership of their disease and they understand why they're receiving particular treatment. You should definitely ask about mutational screening and your chromosome tests, because that will give you important information about what sort of treatment you should be receiving. Sometimes, inevitably, and I've probably done it in the last 15 minutes, doctors speak in gobbledygook, so make sure the doctor is clear. It's also important to consider how stressful this whole process is, not only for you, but also your caregivers and your family. So really do take care of yourself. Look for support mechanisms with family, friends, patient groups, and very commonly counseling can be helpful in this really a stressful period. Monitor your symptoms and side effects and talk to your care team about whether there are any clinical trials of new therapies available. So, in conclusion, I think we recognize now that mutations in the FLT3 gene are the commonest abnormality in acute myeloid leukemia. They help us understand how the disease will behave but also they're very important in terms of identifying whether you're a candidate for a FLT3 inhibitor. So these tests are done on bone marrows at diagnosis, and it's important that they inform your treatment. FLT3 inhibitors are magic bullets, really, that block and kill cells with the abnormalities in the FLT3 gene. And as we've discussed, there are a number of different FLT3 inhibitors, which are useful in different clinical settings. And it's very important that you talk with your doctor about which is the best FLT3 inhibitor for you. And the doctor's advice will be on the basis of randomized clinical trials. Doctors and patients should be working together as a team to put the patient right at the heart of every decision making, and also empowering patients with the knowledge they need to make the necessary information. So, I mean, I guess, in our discussion, we might talk about how biomarker testing is changing how we treat AML. We might want to think about how healthcare teams can make discussions about how biomarker testing is optimally integrated into routine day-to-day care can be maximized, and I have several thoughts in that space. We need to think about how nurses and pharmacists and patient advocates have an enhanced role in interpreting these complex results. We need to make sure that the results are expressed in an accessible manner and don't cause confusion, as they quite often can, even for experienced medical staff. It's important that there's a consistent access to testing capacity for these critical tests that determine treatment choice and outcome. We need to continue to empower patients and their organizations to demand the best possible care is available through access to biomarker assessment. And we also need to be thoughtful this is just part of a journey as you go through your induction chemotherapy and then your consolidation or transplant, and it continues into maintenance therapy. But I wondered whether Ralph might like to just make a couple of comments first.
Well, thank you. Thank you, Charlie. I do not have that mutation, but everything you're talking about is part of the memory of my first year with Dr. Robos. I do have one question about your last slide, and I think it might have something to do with geography and availability of people like you. The idea that nurses, pharmacists, or patient advocates might play a role in helping interpret results. Is that because of the rarity of having skilled oncologists around the world?
I don't think it's necessarily that, Ralph, and I recognize that there's different models, but I remember working with probably the most gifted pioneer of stem cell transplantation the UK's ever had, called John Goldman. And John would always ensure that after he had a consultation with a patient about whether or not to have a transplant, they would then go to a senior nurse. And it was very interesting because I kind of worshiped John Goldman, because I thought he had a clarity of thought and enormous background of information. But the interesting thing was that the experienced nurses on his team would often report that although John Goldman had presented all the information as clearly as possible, the patient had somehow found the consultation process quite daunting and missed on several critical parts of interpretation. And it was the nurse who often was able to help the patient through particular aspects of their care and provide some clarity. So my sense is, I mean, obviously you've been treated by a remarkable physician, Dr. Robos, but I do think sometimes, Ralph, that doctors don't always communicate complex information as well as possible. And also sometimes it's useful to have two opinions and two particular ways of explaining treatment options, but also the implications of particular tests. Is that something that resonates with you, or do you want to comment on?
It certainly does. And maybe I misinterpreted the question. You're saying the doctor will do the detailed analysis, and these nurses and patient advocates will help
Yes,
communicate the results and
I
how
think
it
that's
might
right.
affect the patient.
I think that's absolutely right, Ralph. I think it's working as a team. And of course, the other thing we all know in our own lives, of course, is that sometimes we resonate particularly with particular individuals. So I think it's this idea of a multidisciplinary team. I'm certainly not suggesting that the critical role of discussing the implications of these complex tests is delegated to anybody other than the chief physician. I agree.
Thank you.
So I'm wondering, got a wonderful friend of mine on this call, Lizzie Dean. So Lizzie, maybe we could just touch a little bit on your experience of the benefit of being given options, which include a clinical trial as part of your management. Because, you know, one of the important points I think Natasha has made for us is that as emerging treatments come through, we always want to be asking clinicians whether there's a different way of doing things. And if you could just comment perhaps for a couple of minutes, Lizzie, on your experience of the benefits of a clinical trial.
Yeah, hi. So the reason that I needed my clinical trial, and maybe I mean it's different to the reason why Ralph went on a clinical trial. He kind of opted to. And in my case it was kind of um not my only choice, but it came towards the end of my kind of treatment, where we tried chemotherapy, and that had worked, but then relapsed. I'd had a stem cell transplant, and that had worked also, but then also relapsed. And so then to have the choice of not just kind of giving up there, but being able to go onto a clinical trial, that was kind of it was it's hard to describe, because it was I thought that basically that was the end for me, and I didn't really have anything else where else to go. There was no more treatment options left to try, but because there was this clinical trial available, it meant I had another chance. And that's eventually what put me into remission again and allowed me to survive, basically. So yeah, I think having that extra choice of going on a clinical trial is really important.
And how long ago was that, Lizzie?
So I started the trial in 2017, and I ended it in 2019. So I was on it for about 2 years,
Okay.
until we
6 years
decided.
ago. Still going
Sorry?
strong. About
Yes,
6
yeah,
years ago, it's still going strong, yeah?
yeah. Still, so the results of that trial is basically why I'm still here now today.
Yeah. Great. It's lovely to hear, Lizzie. And I do think it is important that one is able to ask your doctor, are there any clinical trials available? So quite often there aren't, but I think that a unit that embraces putting patients onto clinical trials it is nearly always a good unit, a thoughtful unit, and one that you can be comfortable with. So I'm not sure whether we have any other questions from ambassadors. If you have any, this is your opportunity. Please feel free to share any thoughts. Yes, Vanessa.
Professor, thank you for mentioning counseling. We have quite a big struggle in South Africa to involve the oncologist and the hematologist with introducing psychology or clinical psychologist, but it is so, you're talking about options, you know, for a patient to feel that they are part of the process, you know, doesn't matter on what level, just for them to feel like, you know, it's not just going over my head. I can take a little bit of control. Look, there's not a lot of control that patients feel when they're in this system, because it's such a brutal a treatment plan. You know, you have the diagnosis, you hear all that information, that medical information, and you are immediately plunged into a very brutal biological as well, but psychological process. So, you know, and I really find that if the medical doctor explain a little bit, you know, the importance of seeing a psychologist, from the beginning, they really tend to look. There's still a stigma in seeing a psychologist, but hearing from the oncology team that that is part of our treatment is very, very important. So thank you very much for mentioning that.
Well, Vanessa, just to kind of completely agree with you, I personally think it's really important to emphasize to patients that they're going through one of the most terrifying experiences really that humans can have, loss of control and
Yes.
total inability to predict the future, as well as associated toxicities. And I think that it's really stressful for patients, but also for the carers, and we sometimes ignore the carers. But I'm
Yes.
encouraging my patients to recognize that if they're feeling scared and lost and bewildered, this is a normal reaction to abnormal events.
Yeah,
And that for
absolutely.
many patients, simple counseling, talking to somebody else who's trained
Yes.
in exploring these sentiments is really valuable.
Yeah.
Ralph,
Thank you. Yes.
was this your experience, Ralph?
Well, this is an amazing conversation. When you say entering the most terrifying experience, and I had to make that decision on one day to go into a clinical trial and almost 12 months in bed, 24 hours a day. You know, I sit here 10 years later, and it's hard to explain why I'm one of the lucky ones, but you just really impacted me with that statement, Dr. Craddock, because how do you tell somebody that? And we have some people, including in-law of mine, who elected no treatment because he was a medical surgeon. That was 10 or 12 years ago. So facts are facts, but to think of entering this treatment, you almost have to emphasize a little bit about the positive possibilities.
Yeah, I do think that's right, Ralph. And one has to be really balanced. But I had a young woman who I saw a month ago who had a really terrible story. She'd had breast cancer, and then she'd had chemotherapy, and she got very high risk p53 mutated acute myeloid leukemia. And the story that she'd been presented with was really of unremitting gloom, that there was nothing that could be done. It was important to emphasize to her that she had high risk disease, but that there was still a 50% chance of going into a remission, and that if she had a transplant, things might work out. So we talked that through, and this brave young woman had the chemotherapy, and I just heard last week that she's now in remission. We're looking for a donor, and we've got a route to a cure. So I couldn't agree with you more, Ralph. Patients do want hope, as long as it's reasonable and grounded in fact. And sometimes we can overdo this pessimism. So I guess my final remarks, really, before handing over to Natasha, would be that we've still got so much more to do to improve outcomes of patients with FLT3-mutated acute myeloid leukemia. I think one of the most promising, exciting developments in the last couple of years is the value of real-world data. By that, we mean collecting prospectively, in the going forward in the future, the course and the outcome of patients treated with this disease and correlating it with particular gene changes. And there's a huge opportunity for us all to work together to build up this body of information. And some of the results that are now being obtained using artificial intelligence on these high quality data sets provide profound insights into how we should treat the disease. So as well as clinical trials, let's think about leveraging the potential of data, just the same way that Google want our data. We should be collecting the data on our leukemias so that we can get more and better insights.
I just had the same question. How do you decide on therapies? Do you use a kind of algorithm? And
yeah,
how do you inform patients? Do you use written information material, or do you include patient organizations?
Yeah, so I think it's pretty reassuring, Eric. We now have international guidelines about how you treat particular forms of leukemia. There's one that's published by the European Leukemia Network, which will give a very consistent approach to treating FLT3-mutated acute myeloid leukemia. So we, with a clinical nurse specialist, will talk through that with the patient. We will give them patient information sheets that specifically speaks to this. And we will certainly refer them to websites posted by patient groups. And then we will see the patient again the next day to ask them to write down any questions, things they're not clear about, and go over any outstanding questions. But it is valuable that we more and more have a consensus internationally about how we should treat these particular molecular subtypes.
Okay, thank you.